All right, good afternoon, everyone. Thank you all for joining us. Today is the second week of our master's essay presentations, and we have a fantastic group with us today. We're going to get started right away because each speaker only has 15 minutes total. So they're going to present for 10 minutes and then have 5 minutes of questions. Feel free to put questions in the chat. We'll try to get through as many as we can before moving on to the next speaker. So we're going to get started right away with Alea Lopez. So Alea has a degree she has a Bachelor's of Science degree from Rutgers University, which is the State University of New Jersey, with a major in nutritional sciences. And since she's been here with us, she has focused on maternal, fetal, and perinatal health. And she's going to share her slides and tell you about her master's essay title. So go ahead, Alea.
Thank you, Erin. All right, everybody. To get us started, I'll be discussing today. Oh, let me know when you can see my screen. It's still loading. This doesn't count towards my time.
You can see it
There
now.
we go. Woo! So I'll be discussing equity challenges in WIC modernization for rural and tribal communities. So to get us started, the WIC program is a federally funded nutrition program for pregnant, postpartum people, infants, and young children. So WIC has been shown to support, improve nutritious diets, access to health care, and promote child health and development. In addition to the monthly food benefits families receive, WIC offers nutrition education, breastfeeding support, and referrals to health and community services. During the pandemic, WIC's traditional in-person service model had limited access for families. So in response, modernization efforts had expanded, which included online ordering and delivery of WIC foods. So marking a shift towards a more flexible and family-centered program. And today I'll be discussing WIC online ordering and delivery in the context of Navajo Nation as my case study for understanding modernization in rural and tribal communities. As the largest Native American reservation in the U.S. and also one of the first agencies to test this model, the Navajo Nation is a leader and also presents the opportunity for us to learn about the promise and the potential implementation challenges. So what shapes WIC modernization? Building on the previous slide, this framework shows that online ordering and delivery are shaped by more than just the digital platform itself. For this analysis, I focus on the organizational, environmental, and community levels, specifically 3 implementation conditions, which include the administrative capacity, broadband access, and the retail environment. So together, these determinants shape whether online ordering and delivery can become an equitable access strategy. So my first determinant is administrative capacity. Federal policy, sets these national goals and creates opportunities for the program to upgrade. But given that WIC is decentralized, meaning that it's administered locally through state, territory, and tribal agencies, implementation depends on these existing system dynamics. And one of those capacity components I want to talk about today is the MIS and EBT system readiness. So the management information system is the technology backbone of WIC, and they support the participant from the moment they're enrolled to when they're at the store redeeming their benefits. And some agencies share these systems through consortium models to help reduce costs and improve efficiency. However, these shared systems can also make it harder for one agency to make changes independently. So these updates have to be in alignment with the broader consortium timeline, priorities, and funding. So even when we have something like online ordering available at the federal level, implementation can be delayed if the systems behind WIC benefits aren't flexible. My second determinant that I explore is broadband access on the Navajo reservation. Historically, there's been a lot of underinvestment because of this market-driven model that private providers have engaged with. So there's just fewer incentive to build in rural areas. At the same time, broadband projects on tribal lands often require multiple layers of approval. And these processes are important for protecting the sovereignty in tribal lands, but can also extend timelines on top of already the high construction cost on the reservation. And these structural barriers show up in our broadband subscription data. So only 33% of households on the reservation report having a broadband internet subscription, compared to the nearby states such as Arizona, New Mexico, and Utah, which are at 80 to 91%. And that gap here that we see, is reflected in the limited infrastructure, affordability challenges, and installation barriers that are experienced. And my third and final determinant is the retail environment. So when we have online ordering and delivery, that model can only work if the families that the vendors that families shop at are available, are authorized, and are ready to participate. And some of the challenges that are existing on the reservation include limited grocery infrastructure, high transportation and supply chain costs, limited competition, and these conditions make it harder for stores to keep WIC-approved foods in stock due to managing these operating costs and stocking challenges. So by the bottom of this funnel, those retail pressures become family-level access issues, which end up being fewer vendors, potential delivery gaps, and just overall lower benefit redemption that we see on the reservation. And the next slide I show will show how this plays out. So to our left, we have a GIS map of WIC-authorized food stores on the reservation as of 2025. So these blue markers here are representative of currently active WIC vendors, while these red markers represent stores that previously accepted WIC but are no longer participating. And this is important spatially because nearly half of the stores that once accepted WIC are no longer active. So each red marker represents a place where families can no longer use their benefits. And to our right is WIC administrative data that I had done an analysis on from 2022 to 2025. And this shows where families are primarily shopping. And rural vendors consistently accounted for 50% of total benefit redemption. And we see an increase here of supercenters being also a place where families shop, which is interesting because there are no supercenters on the reservation, only in the border towns. So, these figures show that online ordering and delivery have a potential here, but in our next slide, we will address some of the policy strategies that I had came up with to address some of these implementation challenges. So my first strategy really focuses on coordinating the tribal broadband expansion that is already underway to help with WIC access needs. So prioritizing connectivity for the clinics, retailers, and rural households. And this will allow WIC tools to be used more efficiently, given that not all parts of the reservation have access to broadband. And then my second policy strategy is to strengthen the rural vendor participation, calling on USDA and WIC agencies to provide additional targeted support for these geographically isolated vendors, which can include technology upgrade grants, simplified authorization processes, and more technical assistance in areas where there is no full service grocery store. And that can help ensure, online ordering and delivery doesn't just work for retailers who can absorb those costs, but also strengthen access in these rural communities. And building on these broader policy strategies, these near-term recommendations focus on what can be done during this transition period. So first, using WIC data to help guide action. The administrative data really allows us to show one key point that I've learned in this work is that what gets measured shapes what gets prioritized. So having this information about vendor status, redemption patterns, and geographic access can help put our attention where funding can go to the most urgent areas. And in response to this decline that we are seeing, I propose, a vendor recovery initiative. And this will help identify vendors who recently have left the program, get an understanding of what barriers they face, and what support do they need to re-engage them. And then after these changes occur, really engaging the community networks to help making sure families stay informed and maintain participation during modernization efforts. So to close, modernization for WIC alone doesn't mean that participants have access, and these access that we're seeing related to online ordering delivery shows that we need system level investment to make sure that families are benefiting equitably. And I would just like to make some acknowledgments. A graduate degree is never completed alone, so I really appreciate my family, mentors, colleagues, and friends who supported me in every step of the way, Dr. Gross and the Navajo Nation WIC team, Dr. Page as well, and just all my loved ones. So thank you.
Great job, Alea. That was really fun slide at the end. That's a really great project, and thank you for sharing your findings. We have a few minutes for questions if folks want to put them in the chat or come off of mute. Chelsea, a question?
Hi guys. Yes, I do have a question. Great presentation, Alea. I just wanted to ask a little bit more about clarity on how vendor types affect the feasibility of WIC online ordering and the delivery on the Navajo Nation.
So yeah, in my experience on this project, I really saw that different vendors have different strengths and limitations for the feasibility of doing online ordering and delivery. So Walmart supercenters, have a stronger inventory, staffing, and just overall online ordering system. But they are located off the reservation, 30 to 60 miles away on top of already the longer travel distances that families have to do compared to, our local rural vendors who are more accessible to families, but may need that extra support to do things like Walmart has already involved. So stocking, technology, and delivery logistics. So I think with WIC online ordering and delivery, it can be implemented in a one-size-fits-all model. So I think that feasibility really depends on tailoring modernization to support the realities of the different vendor types. So yeah, thank you, Chelsea.
Great question. I have a question. Oh, it looks like Dipti has a question. Go ahead.
Hi, Alea, great job. I was really interested to hear about your vendor recovery initiative. But I was just wondering, like, what you were finding about why some of the vendors stopped participating.
Yeah, thank you, Deepti. So what I had found really with the vendor loss on the reservation, that it was tied to this technology and operating challenges. So some of the vendors had experienced like limited connectivity overall, and that had made it difficult for when families were redeeming those benefits in the store with their EBT card. And so they weren't able to purchase these foods, and it made it just difficult for family and the shopping experience. So fewer families then were not coming in to redeem their benefits, and it became harder for stores to really justify maintaining the required minimum stock of WIC-approved foods, especially the perishable items like fresh fruits and vegetables. So over time, WIC participation became just less feasible for some vendors, which had contributed to their exit. And I think also in my research in understanding the retail environment overall was that during the national transition from paper checks to the electronic benefit transfer card, studies had found that vendor loss really happened with our smaller independent retailers. And because of these new technology requirements, staff training, operating cost, it led to their exit as well. So I think Navajo Nation really experiences a broader pattern that was seen with the modernization in these technology improvements, but intensified by these structural conditions such as connectivity and access barriers. Yeah, thank you, Deepti.
And for like a quick question, quick answer. If anyone has a quick one for Alea? Alea, how well do you think your findings translate to other remote rural areas beyond either a reservation setting or the Navajo Nation specifically?
I definitely think that they show us that we have to, really look at the data that's available. The administrative data that we had was just sitting there, and oftentimes we are focused on the enrollment part of WIC, making sure families are in the program. But I think with this project, we really saw like where are families shopping, and the large decline too really made this an issue that needed to be further understood. So I think with other rural agencies, it'd be really interesting to see where their families shopping, because some of the barriers that we do see with Navajo Nation are also experienced by rural families. And also to point with tribal agencies, not all tribal agencies experience broadband issues in the same way that Navajo Nation does. So there are some tribal agencies who have no problem with broadband subscription.
Those are great points. Thank you so much, Aaliyah. Wonderful job. And I think we will move on to our next speaker. So Cassie Hewett is next up. Cassie has a Bachelor's of Science from Pepperdine University with a major in biology. And she is in our women's sexual and reproductive health area of interest. And I will let Cassie tell you about the title of her master's essay.
Hi. So today we're going to be talking about information pathways, maternal perceptions, and early paternal information seeking of expectant fathers during the prenatal period. So why focus on fathers? Father prenatal involvement improves maternal and infant health. Fathers want to be engaged and mainly use informal sources for information. Informal sources are non-academic, unverified, or personal channels that provide quick, often subjective information. Examples of this are social media posts, blogs, and casual conversations. Fathers also have an unmet need for perinatal education, and there's limited research on information sources, information seeking, and low income and Black fathers in general. So the bottom line here is that we don't know how fathers prepare for pregnancy and infant care. My study questions are, first, where do fathers get their information? Second, do mothers understand where fathers get information? And third, how do fathers' background characteristics relate to the sources they use? The study used data from the Text for Father pilot intervention study, which was approved by the IRB. They did a cross-sectional baseline survey collected early in pregnancy for expectant fathers with less than a college degree, as well as their birthing partners who were less than 25 weeks gestation. So we had 97 father-mother pairs from an urban mid-Atlantic sample. For measures, we looked at information seeking, which was a yes or no question, and then we asked them their information sources, which had 18 options. One of those was another source, which was a write-in. And then for data analysis, we used frequency, which allowed us to describe how often fathers cited different information sources and their background characteristics. We used percent agreement and Cohen's kappa to assess alignment between mother's perception of father's information sources and the father's reported information sources, and then use a Fisher's exact test to examine associations between background characteristics and information sources. The sample was an average of 31 years old, mostly Black, employed, and had at least a high school diploma, and just under half of the sample were first-time fathers. My first key takeaway was that fathers are seeking information. Over 80% reported looking for pregnancy information, and about 2/3 reported looking for infant care information. For father information sources, we saw that fathers don't rely on just one source, and they use a mix. Baby's mother was the most endorsed source, with 78% of fathers saying they use them as a source for information about pregnancy, and 77% of fathers reported using the baby's mother as an information source for infant care. Whereas for home visiting, only 2% of fathers reported using them for pregnancy information, and 1% reported using home visiting for infant care information. Here we're looking at whether there was an alignment between what mothers reported the father's information source was with what the father actually reported was their information source. What I found was that there was not much overlap between the two, meaning mothers lacked understanding of father's information sources. For example, the highest kappa value for the pregnancy information source was the internet. There you go, at zero point 0.4, which indicates fair agreement. And this means that agreement between father's reported information source being the internet and the mother's perception of them using the internet was fair. So there was some shared understanding, but still notable disagreement. Similarly, the highest kappa value for infant care information was for the father's mother at 0.45, which indicates moderate agreement. For my third study question, I explored associations between background characteristics and information sources. To do this, I looked at the top 5 reported information sources so that I could keep a relatively large proportion of the sample. And the top 5 information sources were baby's mom, father's mom, the internet, friends, and doctor. Importantly, these results come from separate bivariate analysis using a Fisher's exact test to see how the presence or absence of the background characteristic was associated with the information source used. First-time fathers were more likely to report internet and friends as sources of information for both pregnancy and infant care versus fathers that already had children at the time of enrollment. And reliance on the father's mother for information on infant care was associated with less than a high school education when compared to all other education levels. Whereas fathers with some college education reported using the internet more for information on infant care when compared with all the other education levels. There was also a significant association between race and internet use for infant care. White fathers reported higher use compared to Black and other racial and ethnic groups. So for our key takeaways, the majority of expectant fathers in this sample were actively seeking information. 82% of fathers reported looking up pregnancy-related information, and 68% reported seeking information on infant care. Rather than relying on a single source, these fathers used a mix of sources, with the most common being the baby's mother, their own mother, the internet, friends, and doctors, highlighting a layered and largely informal information network. This points to what we can think of as a layered information ecosystem. Importantly, this challenges the idea that fathers are disengaged. Instead, they are actively engaging, but often through fragmented or informal networks. Second, when we look at agreement between mothers and fathers, the kappa values were only moderate at best, and this indicates relatively poor alignment between mothers' perception of fathers' information seeking and what fathers actually reported, suggesting there's a lot of paternal engagement that may be happening in ways that are not fully visible to their partners. And in terms of background characteristics, first-time father status showed the most consistent differences in information source use, particularly with greater reliance on the internet and friends. There were also some differences by race and education level, but interestingly, more demographic variation appeared for infant care information sources, which may be influenced by the timing of the survey, since all data were collected during pregnancy rather than after the child was born. As for our limitations, we do have limited generalizability because we have that smaller sample size of 97. We use self-reported measures, which can lead to recall or social desirability bias that I anticipate would bias the association between the background characteristics and information sources toward the null. Most of the sources that we asked about were informal sources. We also couldn't measure the quality of the information that they were getting from these sources, and the surveys were taken early in pregnancy and not after the baby was born, which could influence the information collected about infant care. As for strengths, we examined sources of information for both pregnancy and infant care. We used an urban, predominantly non-Hispanic Black sample with lower income, which are historically left out of research. We had a dyadic design, and we captured multiple dimensions of information sources, seeking, and concordance. There are some clear implications for public health practice here. So given that one of our limitations was that we don't know the quality of the information fathers are receiving, father-inclusive prenatal care should be common practice so expectant fathers have access to formal, credible information, and future work should examine both the quality of the information and the pathways fathers are already using so that we can better connect them to evidence-based sources. Importantly, fathers already rely heavily on family and digital networks, so intervention should leverage these existing pathways rather than attempting to replace them. For my acknowledgements, I would like to thank Dr. Arik Marcel for his mentorship and guidance, Dr. Moa Kande and Dr. Radha Rajan for their support on this project, and my father, Gary Hewett, whose example inspired my interest in researching fatherhood and paternal engagement. Thank you.
Wonderful job, Cassie. So interesting to hear that perspective, including fathers. I love it. Does anyone have any questions for Cassie? So many hand claps. Anyone? I see a hand raised. I can't quite tell who it is. It says Selnaki one. Is that a hand raised?
Nope, no hand raised.
Oh, sorry about that. All right. I have a quick question. First of all, how did you recruit for this? I just wondered if fathers signed up for a study about father engagement. Maybe they were already a little bit more engaged.
Yeah, great point. I am pretty sure that they were recruited at Hopkins maternity clinics during their like prenatal doctor's appointments.
Could mothers sign the father up without their knowledge?
No, the dad had to be aware.
Yeah, I was just thinking if the mom signed up for the both of them, that would be kind of interesting. Anyone have a question for Cassie? Feel free to put it in the chat or to raise your hand. I did find it fascinating that fathers, the number of fathers who indicated their own mother as a source of information, even sometimes surpassing their the mother of their child. So.
Yeah.
Will you be able to stay on with this project, or has your time with the project ended?
Yes, I will be staying on with the project. We're doing the national data now. So this was just from Baltimore City, and we've moved on to bigger and better things.
Fantastic. That's fantastic. Great. Any other people are mentioning that it's a under-researched topic in parenting, which it certainly is, for sure. Any other questions for Cassie? And what are your next steps after graduation, Cassie?
Um, we'll see. That's a big loaded question, Erin. But I'm continuing with Text for Father and hopefully doing some more menstrual care work as time goes on. So
That sounds fantastic. It's been such a pleasure working with you, Cassie. This is a great presentation. Wonderful job. So thank you so much for your presentation, Cassie. So we will move on to Drishti. So the next presentation is by Drishti Mukherjee. Drishti has a Master's of Science degree from Neotia University with a major in biotechnology. And Drishti is part of our women's sexual and reproductive health area of interest. And so I will have Drishti introduce her master's essay title. So go ahead, Drishti.
Hi everyone, my name is Drishti, and I was looking at the links between obstetric complications and postpartum depression. My PI advisor, lifesaver, and essay reader has been Farah Qureshi. I owe her everything for this. And Dr. Sally stepped in because right now she's on maternal leave. So I'm going to go ahead and introduce you to the topic. Approximately 10 to 20% of women globally experience postpartum depression. We know the psychosocial story well. Prior mental health history, low social support, financial hardship, these are well established. But when I started reading the literature for this review, I kept coming across a different assumption that the physical experience of birth itself, the bleeding, the emergency surgeries, the severe tearing must also be driving depression. It seems obvious, doesn't it? A traumatic birth causes trauma. But I wanted to know whether the evidence actually supports it, and what I found was far more interesting than just a simple yes or no. To investigate this, I reviewed 26 studies across 11 countries as a part of a broader project led by Dr. Qureshi, following the Whitmore and NAF 5-stage framework. I focused on particularly 5 complication types: emergency cesarean section, postpartum hemorrhage, perineal tearing, all the degrees 1 to 4, perineum hysterectomy, and severe maternal morbidity. I was strict about this inclusion. Only studies that used validated depression tools such as EPDS, BDI, PHQ-9, or had a clinical diagnosis, and all of these that were assessed within a year of birth. These were all quantitative designs only. No general distress surveys were included. I wanted to know what the rigorous evidence actually says, not what we assume. Now, what it says is this: no single obstetric complication consistently and independently predicts postpartum depression. For the more common complications, cesarean sections and perineal tears, across 15 studies, findings were evenly split. Some showed elevated risk, some showed no effect at all. For life-threatening complications, the signal was stronger. They shifted dramatically depending on where in the world the study was conducted. The same complication, opposite conclusions. Now I want to be clear. The graph you see here, this is inconsistent. The inconsistency is not the problem with the evidence. It is an evidence itself. Because once you ask why the findings keep splitting, you start to see what's actually going on. And it leads to 4 insights that I genuinely find useful for clinical practice. The first one is the most counterintuitive. It is not the procedure that drives depression. It is how the woman experiences and makes sense of it. Take, for example, cesarean sections. Suzuki 2022, and I want to flag this is unadjusted data from a single Japanese cohort, found that elective cesareans produce the highest depression rates of all, 27.5%, compared to 11.9% for emergency C-sections and 5.9% for vaginal delivery. A planned surgery caused more distress than the emergency one. When you sit with that finding, it actually starts making sense. When the birth does not go the way the woman imagined it, even without an emergency or any danger, the gap between expectation and reality is its own kind of wound. Then Gris or et al. 2022 added another layer. There is no direct path from emergency section to depression. He said that the PTSD symptoms are what causes it. So the surgery is not the variable. How the birth is lived, remembered, and made sense of, that is the variable. The second insight follows a simple logic, but plays psychologically rather than physiologically. 3 enormous registry studies, Liu et al., with nearly 500,000 women in Sweden, Brody with over 390,000 in Denmark, and Unukula in Nigeria, all found no significant link between postpartum hemorrhage and depression. So you might conclude that bleeding simply does not matter, but then Eckerdell 2016 shows us what others did miss. Hemorrhage alone does not predict depression, but anemia discharge, the physical consequence left behind by that bleed, more than double the risk with an adjusted odds ratio of 2.29. It is not the event itself, it is what the event leaves behind in the body. And that reframes everything. The two studies that did find a positive association, Wang and Parry Smith, were likely picking up that anemia pathway without fully accounting for it. The practical implication is straightforward. After a postpartum hemorrhage, check hemoglobin at discharge. That is your signal, not the volume of blood lost. The third insight brings us to perineal trauma. And here the story gets even more nuanced. 6 studies, very mixed results. Overall, no significant association. Asif, with over 3,000 women, found an odds ratio of 1.4, not significant. But this within the same study, when they looked at women with low resilience scores, the odds ratio jumped to 4.8. Same physical injury, same clinical setting, radically different mental health outcomes. What changed was not the tear. It was the psychological resources that the women had going into the birth experience. And that pattern holds across all 6 studies. Dunn and Khalaf found associations. Fairbrother, Faisal, Steen did not. And Asif helps explain why they differ. The clinical implication is not to treat every woman with perineal trauma as equally at risk. It is to find women who are already psychologically vulnerable and direct resources at them. The fourth and final insight is about context, and it might be the most complex. The largest single effect in this entire review was by peripartum hysterectomy with an odds ratio of 2.41. With over 1.2 million cohort from South Korea, severe maternal morbidity, more broadly, Anesthesia 2024 found a 22.6% risk of postpartum depression diagnosis in a large US cohort. Strong signals. But then Harlot in Tanzania and Noehati in Malaysia found no significant association at the same point. Same complication, again, opposite conclusions. Two things likely explain the gap. In US, insurance-based health records probably capture more diagnosis. And in the other cases of Tanzania and Malaysia, the lower income settings, strong community and family structures may genuinely absorb some of the psychological distress. We cannot fully untangle these two explanations and that itself matters because it means the context is not something we can just adjust for in a regression model and move on. It is a moderator. It shapes what happens to women after these events, and any clinical response has to account for it. So, where does it leave us? 26 studies, 11 countries, 5 complications, and no uniform predictors. But that's not a disappointing conclusion because what this review actually gives us is something more useful than a simple risk list. It gives us a framework for thinking about experiences with which women, thinking about with which women, after which experiences, in which contexts are most vulnerable. After postpartum hemorrhage, the signal at anemia at discharge, not the bleed itself. So treat anemia aggressively. After cesarean sections, the pathway to depression runs through postpartum PTSD. So screen for trauma symptoms, not just the mood. And across all complication types, the single most consistent moderator is women's psychological resources going in. So identify low resilience and poor antenatal mental health early, before the complication even arises. The physical event is not the entire story. What follows it in the body, in the mind, and in the world around the women is where depression actually lies. Thank you. And I would like to again acknowledge Dr. Farah Qureshi and all my people who are here right now supporting me all the way from India and the team of PFRH, everybody, Sally, Erin. Thank you so much, all of you.
It's fantastic, Drishti. I can't believe you got through all of that in such a short period of time. That was a lot of work. I really appreciate your presentation. So we have some time for some questions for Drishti. And again, you can put them in the chat if you don't want to come off of mute, or feel free to raise your hand.
I had a quick question. So I was wondering, for someone who is interested in doing scoping reviews, what was your experience like doing this review?
Honestly, I think Dr. Qureshi can tell you best about this. Uh, the biggest distraction I had was I had a topic, right? I was looking at birth complications and depression. But when I looked at the data, there were so many variables, and I would easily get distracted and I would try to look at, oh, but what about this other co-founder that's there? Can we look at it? So, if you want to ever do a scoping review, when once you establish your topic, try to stay on it because I remember Dr. Qureshi and I went back and forth, her just reminding me to stay on the topic and not look at the other complications, even how interesting they are. So I think that was the most interesting part of the scoping review. And yeah, because these did not have a fixed variable. So if you're looking at something that is going to come up with results which are going to be very vast, as you saw in my data, none of them said, hey, I agree with you. They didn't. They probably said, I understand that, but this is where I don't agree with you. So if you have data which is very I won't say controversial, but not in giving a similar pattern, is where you're going to use a scoping review. And I thoroughly enjoyed it. I had brilliant support. So first years, if you're hearing, find Farah Qureshi and work with her.
That's awesome. Thank you. Ahana, do you have a question?
Hi, Drishti. Great work. I just had one question for you. So I'm sure this was very challenging, but you did really, really well. But if you could go back and do this project again, is there anything specific you would change and do differently?
That is such a good question. I would, like I talked about, I would try to focus on, because I think I took up a lot of time while doing the project because I was getting distracted. And because this is a smaller part of an integrative review, Dr. Qureshi was already looking at many, many aspects. And I was only looking at depression. She was looking at psychosis, she was looking at PTSD, she was looking at all of that. So she had all the data, and we had more than 80 papers, I think. And from there, I came down to 26. So I think in the beginning, I would try not to get distracted again and stay on my topic, even though it's so interesting once you start reading. And especially, I want to mention this paper, 2022 Suzuki Japan cohort, the only paper that said elective cesarean sections had the lowest effect on postpartum depression. I think that was a very interesting paper. So I think if you want to look into that, that's a very interesting paper, 2022 Suzuki. But yeah, coming back to your question, I think I would try not to get distracted from the beginning.
Perfect. Thank you.
Thank you, Drishti. We have one in the chat, and then actually, Ali, if you want to go first, and then we'll go to the chat.
Sure, great presentation, Drishti. It was fantastic to hear all the amazing things that you found. And it seems like a lot of work that was put into this. I had a question about like next steps. So as I was listening to this, I was also reflecting on a woman very close to me in my life who went through postpartum depression. Obviously, I was not there at the time, but I wondered about like the social support systems that could have helped her at that time. And I wonder if something in the future, like next steps, I want to pick your brain on this, would be to see obstetric complications plus minus support system. So women who have obstetric complications plus have a great support system from their partners or families, and those who do not. And if that further like adjusts that difference. And the other thing I wanted to also ask you is if there is value into distilling these experiences by country and seeing how the United States did, how Europe did, how Asia did, specifically South Asia, because social support can be so different. Obstetric complications can be so different in different parts of the world. Thank you.
Absolutely, I completely agree with you. And I think the first step which I realized while doing it is never generalize. Even when I talk about the US cohort, I would disagree and say I will not generalize US because different states have different policies, different states have different accessibilities, and everybody's experience is different. So I think every woman should be catered to differently individually. They should start in the beginning, and they should be looked I started by saying we should look at only one paper, unfortunately Asif's paper, looked at the resilience factor, which I think in 2014 was introduced to the studies. So it's an analysis where we check, you have to score around 126 on a 203 scale. There are a lot of questions that are asked, and that tells you how the woman is going into the pregnancy. If she's coming with certain types of mental illnesses, or just like I said, everybody's experience is going to be different going in there. So first we have to evaluate how the woman is walking into that experience with. What is she walking with? Once we identify that, then we can accommodate and individually cater the right kind of resources towards her. So I think it's a very individualistic thing that we have to do. And even when I say Asia, I'm going to tell you that it's going to be so different from, even if I talk about my own country, which is India, it's going to be different from people in Rajasthan, and it's going to be different experiences for people in Bengal. It's just everything's different for individual people. So yeah, that's what I think people should focus on, individually treating everyone.
Thank you, Drishti. That was a great question. Great answer. There is one question in the chat, Drishti. Maybe you could take a minute to respond because I think we're out of time. But wonderful presentation and great project. And congratulations on such great work. So we are going to move on to our fourth speaker, Sanaah Yousef, who has a Bachelor's of Arts degree from the University of California, Riverside, with a major in public policy. And Sanaah is part of our women's sexual and reproductive health area of interest. And I will let her introduce her master's essay title. Go ahead.
Hi, can you see my screen? Yeah, okay. Hi everyone, my name is Sanaah, and today I will be presenting on my scoping review, which is on reproductive violence against Indigenous, immigrant, and minoritized women as a method of state control. My research questions are, how do governments exercise systemic reproductive violence against women, and what are the mechanisms through which state-sanctioned reproductive violence and coercion are enacted? So a bit of context behind my topic, reproductive violence and coercion has been used historically as a tool to reinforce patriarchal and colonial power structures. Governments have implemented strategies to control reproductive autonomy, including medical abuse, intimidation, economic coercion, laws, policies, and frameworks. Some key historical and contemporary examples of reproductive violence against women of color include the arrival of Christopher Columbus and his fellow Spanish conquistadors in 1492, who subjected indigenous women to sexual violence and exploitation through colonial control. Further along in Virginia, legislators in 1662 codified enslaved Black women's childbearing autonomy, ensuring that their children inherited their enslaved status through chattel slavery. The codification ensured that enslavers could maximize economic gain through forced reproduction and childbearing. And then more recently, the whistleblowing of forced hysterectomies at ICE detention centers in Georgia, where there were forced hysterectomies performed on immigrant women who had difficulty understanding and consenting to the procedure. The current gaps in literature include the lack of studies focusing on the intersection of the state or government authority using reproductive violence as a method of control or surveillance. Moreover, there were limited studies on the institutional levels of reproductive violence and coercion. My scoping review's objective is to examine the evidence on reproductive violence and coercion, including how it's enacted directly and indirectly through state policies, systems, and practices affecting Indigenous, immigrant, and minoritized women. So for my methods for this review, I followed the PRISMA checklist and guidelines for systematic reviews. I used PubMed, Scopus, Policy Commons, and Embase as my databases. I screened articles using key concepts such as state control, government policy, occupation, reproductive violence, reproductive coercion, and forced sterilizations. Additionally, I completed a more targeted screening on select countries that have a history of settler colonialism and or genocide against Indigenous, immigrant, and minoritized communities. These countries include the US, Canada, Israel, England, and Peru. My inclusion criteria for this review included articles that examine the effects of reproductive violence on Indigenous, immigrant, and minoritized women, articles that focus on state-sanctioned violence conducted in any settings, but not limited to jails, detention centers, and healthcare systems, focused on all women, written in English, published peer-reviewed journal articles, reports, book chapters, and relevant gray literature. And my exclusion was examining the exposure of reproductive violence at the individual or spousal level and books or conference abstracts. So my overall results, I extracted 30 studies with the majority published after 2015. Most were qualitative and focused on North America with the heavy concentration in the US and Canada. Here on this map, you can see other countries that were mentioned in the studies, like Ethiopia, Australia, Argentina, Chile, China, and India. The perpetrator findings showed that all articles identified the perpetrators to be government-based actors and officials. The most frequently mentioned and described perpetrator was the US government. Additionally, perpetrators included healthcare providers, enforcement authorities like police and military, social workers, and eugenicists. So for my findings, I grouped the findings into three main mechanisms: legislative control, direct coercion, and economic inducements. Most studies described overlapping mechanisms, particularly for legislative control and direct coercion. 4 articles described legislative control, direct coercion, and economic inducements. 4 articles described only the use of legislative control, and 1 article described the use of direct coercion. Mechanisms mentioned in the literature include forced and coerced sterilizations, abortion policies, population control policies, contraception policies, reproductive coercion, sexual violence, lack of consent, child apprehension, and forced births. My literature was also classified into one or more of three outcomes, including the limitation of reproductive capacity, control of bodily autonomy, and forced reproduction. The limitation of reproductive capacity reflects the broader colonial and genocidal or institutional structures that enforce assimilation and limit reproductive capacity. Indigenous, immigrant, and marginalized women are disproportionately targeted by violent policies and regulations that restrict reproductive autonomy. In North America, especially Canada and the US, Indigenous women were forcibly sterilized and surveilled by settler colonialists aiming to eliminate Indigenous communities. Similarly, in Peru, the National Program of Reproductive Health and Family Planning was enacted to sterilize Indigenous communities through tubal ligations. These examples show that the government tries to regulate and dictate reproductive autonomy in an effort to promote racial survival and Eurocentric standards. For the control of bodily autonomy, it highlights the direct and indirect mechanisms that restrict reproductive autonomy through policies, programs, and procedures. Examples of direct mechanisms include forced sterilizations and abortion contraceptive therapy, coercion for Aboriginal women in Australia in an effort to promote racial hygiene. Indirect mechanisms include the threat of welfare benefits for Black women and girls in the South if they rejected sterilization procedures. Additionally, in Israel, Ethiopian Jewish women were forcibly and coercively administered contraceptive injections before immigrating to Israel. The Israeli government utilized this fear tactic to coerce women into receiving Depo-Provera, which is a contraception injection, warning them that if they did not receive the contraceptive, they would not be able to immigrate. For forced reproduction, it refers to how Indigenous, immigrant, and minoritized women are subjected to forced reproduction and coercion through mechanisms like forced birth and pregnancy coercion. Examples of forced birth include the forced childbearing of enslaved Black women, where after the transatlantic slave trade, white enslavers would sexually assault and force enslaved Black women to bear as many children as possible to increase their wealth. Another tactic is abortion bans. In Iran, the Rejuvenation and Population and Protection of the Family was enacted to ban and increase population growth. Some limitations to my study include search recognition issues, as PubMed did not recognize Palestine as a mesh term. The terms provided were the Gaza Strip, Palestine, the Near East, and the West Bank. This lack of acknowledgement limits the literature explicitly mentioning Palestine or may have hidden relevant results in the study. Additionally, my search strategy might have narrowed my results, which could have excluded reproductive violence terms like sexual assault and physical abuse, resulting in an underrepresentation of certain experiences. This review demonstrates that reproductive violence is embedded within state, government, and healthcare systems. Racial hierarchy fuels reproductive violence and coercion practices, particularly in settler colonial nations where reproductive control is tied to the idea of racial survival. These mechanisms exert control, humiliation, and fear over women's bodies across contexts such as occupation, detention, and colonization. It is important to recognize that reproductive violence is not only physical, but also psychological. Indigenous, immigrant, and minoritized women's reproductive autonomy and experience of violence extends to their right to parent. For example, in Canada, Indigenous children were forcibly removed from their families and placed into Indian residential schools to basically assimilate into the Eurocentric standards and values. While Indigenous women were able to bear children, state systems often denied them the ability to raise them, reflecting broader effects to disrupt communities and maintain racial hierarchies. These practices are not just historical, they are ongoing. Contemporary examples include the reversal of Roe v. Wade, documented cases of forced sterilization in ICE detention centers, and continued reproductive control in the context of the Palestinian occupation. I would like to thank Dr. Shada El-Nakib for her support, guidance, and mentorship throughout my project and my time in the program, Wilson for conducting screenings of articles with me, and my friends and family for their love and support. Thank you.
It was a wonderful presentation, so important, and again, so much work that you shared in such a brief period of time. So thank you so much for sharing that. Wonderful. Lots of accolades across the Zoom room. We have some time for some questions. Again, you can put them in the chat or raise your hand or come off of mute. I was wondering, did you start with a framework for how you approached this topic? This is a topic I don't know as much about, but the types of policies, I think you said legislative control, direct coercion, and economic policies. Did you go in like expecting to have those um, types of studies that you were looking at using a framework, or did that come out of the search after the fact?
Yeah, so I followed this definition by an article by Morgans and Roberts that defined reproductive governance and reproductive violence. So it described it as the use of legislative controls, economic inducements, moral injunctions, direct coercion, that kind of stuff. And then as I was doing it and I was reading more about um, the types of reproductive violence and everything, I added on to the definition of parental autonomy and the right to parent and that kind of stuff for it to encompass not only just the physical aspect, but also the psychological aspect.
Really, really great way to approach this really important topic. So thank you. That was great. Does anyone else have a question for Sanaah? What types of journals were many of these articles published in? Were they in more of the public health literature? Did you see them in like the anthropology or kind of social sciences? Or what kind of where is this type of work typically published?
I think it was mainly public health, and then also there were a lot of great literature, so I did look at like human rights violation, like articles that were submitted to the UN and stuff. So a lot was like from policy commons as well, if that makes
Yeah.
sense.
No, it does. It does. Yeah, I know it's really fascinating and so comprehensive. And I really again appreciate that you took on such a project that it involves so many different disciplines and really cross-cutting. So it's really a great job. We have about 2 more minutes for questions if anyone else has a question for Sanaah. Do you have plans to publish this scoping review?
Yes, I hope so.
You should.
With
It's
Dr.
really
Shepard.
well done. Yeah,
Thank
that would
you.
be fantastic. And are you looking at a public health journal or an anthropology journal or social sciences or?
No, not yet. I'm still like doing the edits for it, so
Mhm.
just want to get that out of the way first.
Yeah. No, it's really great job. Wonderful. Well, thank you again for this great presentation. And if anyone has any additional questions, you can put them in the chat for Sanaah. So great job. All right, we have one more speaker to go. This has been a great session so far, so really enjoyed all the speakers. Sohan Park is up next, and she's going to share her screen. And Sohan has a Bachelor's of Arts from Smith College with a major in chemistry, and she is part of our Women's Sexual and Reproductive Health area of interest. And Sohan will go ahead and read your master's essay title and get started when you're ready.
Can you all see my screen? Let me just start the timer so I keep the 10-minute limit. Hello, everyone. Thank you so much for being here to hear my presentation. Today, my essay focuses on fear of infertility and perception of infertility and how it's impacted the social consequences of infertility, which ultimately leads to some reproductive health decisions, which I look into, contraceptive use and early childbearing among Rohingya young adults in Cox's Bazar. So before going deep into the project, I wanted to first define infertility. According to World Health Organization, it's a failure to achieve pregnancy after 12 months or more of regular, unprotected sexual intercourse. And infertility globally impacts around 1 out of 6 people. And it's still a very under-researched issue, especially in low and middle income countries or humanitarian contexts. And also in many settings, childbearing is very closely tied to marriage, identity, and social value. And if you think about it and flip the side of it, unable to bear a child is also closely tied to negative impact on social values, and it might have a negative impact on the marriage and one's identity as women or men. And in this project, I looked at how people perceive infertility and how those perceptions impact the social consequences, which ultimately leads to reproductive health decisions and how fear of infertility affects the decisions. And so for the population that I looked into, are Rohingya refugees in Cox's Bazar. This is the map. I think it's from 2023. It says the total population is 9,500K, but right now there's over 1 million Rohingya refugees currently residing in Cox's Bazar, Bangladesh. The number surged after 2017 mass violence from Myanmar, where a lot of refugees escaped to Bangladesh, and all of the refugees currently live in the camps where there's highly restricted mobility. There's not a lot of education or financial means to sustain themselves, and very limited healthcare services. And among those limited healthcare services, there's also sexual and reproductive health services. But a recent study shows that there is still there's a lot of barriers for easy and access to SRH services, and infertility is not the priority in the camp. So for this secondary qualitative data analysis, my bigger data source came from a larger mixed method study, which was conducted in Cox's Bazar, Bangladesh between 2021 and 2023. And since I focus more on the infertility side, the scope or the transcript that I read mostly were the married Rohingya young adults aged between 14 to 30, and 28 in-depth interviews with 16 female participants and 12 male participants, as well as 10 focus group discussions to see more of the community norms and social norms, which compose of 6 female groups and 4 male groups. And for the data analysis, the themes around infertility, social consequences of infertility, timing of first childbearing, and factors that could impact fertility decisions were probed. And among this, I have incorporated thematic analysis where I compared across transcripts to explore differences and similar patterns that could come up across the excerpt, and specific emphasis was put on the gender and age at first marriage. So looking at the findings, my first finding was about the childbearing and the perception of childbearing as an expected outcome of marriage. As you could see problem from the quote 1, as having a child is considered the core value of marriage, and that is perceived as the purpose of marriage. Being infertile signifies that women are not living up to their values. So it really shows that childbearing among Rohingya refugee community acts as a central purpose of marriage, and fertility is like a proof of a motherhood for the women. And if you look at the other side, unable to have a child in a short amount of time after you get married was treated as an immediate problem that needs to be solved. And common practices to address the challenges for delayed childbearing, as you could see from the quote, the second quote is going to traditional practices, religious leaders giving them amulets, taking water readings, and some also recount that they went to the hospital, but it was only if that was accessible and they have the financial means. And looking at how important childbearing is for the marriage and serving the purpose of the marriage, I looked deeper into what are the consequences of not having a child and being infertile. And a lot of the transcripts and the common patterns that came out were that women are disproportionately blamed for infertility. And some of the main social consequences were social stigma, accusations, and second marriage. Social stigma, women were often blamed and labeled as barren, and they were blamed for bearing the full responsibility for not being able to produce a child or grandchildren if the accusers are the in-law families. And the second would be the accusations from families, neighbors, or husbands. This quote really shows well about the accusations and what consequences that women feel. So I'll just read it out loud. When I used to have periods, he used to get angry that I had taken birth control. He used to shout at me and doubt me all the time. So accusations came from different forms. Some accusations came from you might be secretly using contraceptive use, and that's why you're not giving a child to me. And some accusations would be just questioning the motherhood and the woman's social value as a person, and also it sometimes lead to the physical violence from husbands. And another emphasis on consequences was the second marriage. Marriage in this context is not just a relationship issue, but it encompasses a social and financial security. So marriage was a means for the women to gain a social value in the community and have a means to financially support themselves. So the threat for second marriage from the husband was, as in quote, I'm scared about that fact. He will no longer look after me or love me. And this really shows that childbearing was used as a means to support their contain their marriage so that they could financially and socially support themselves. And this conception and ultimately the fear of infertility really dictates the timing of early childbearing, even when some women felt like they were not ready physically or mentally. And this pattern has been especially common for women who married before age 18 and had a childbearing before age 18. They felt like they were not physically ready and not mentally ready for childbearing, but it was socially necessary, so they had to um, prove their fertility. And similarly, the contraceptive myth around the community about using contraception before first childbirth will lead to the permanent infertility also impacted the fear of fertility and also led to women avoiding contraceptive use. The second quote says, I think it might have some effect on fertility of a woman. I have heard from others, no one should take any risk about it. This might have some side effects that we don't know. So having a baby is safe. A safe measure in terms of biomedical, it might have a different connotations than a social value in a sense that a lot of women, especially when the child marriage is common, they get married before age 18 and they have a child during their adolescence or young adults, which could have an adverse maternal and neonatal outcomes. So it is not considered safe in terms of the medical and for the health value, but it was considered safe in terms of the socially acceptable way. And some of the implications from this finding was that it, as I mentioned, it's particularly relevant for married adolescents who, in these settings where child marriage is still very common, they still have to undergo the adolescent pregnancy, which could lead to adverse maternal outcomes and medical complications. And a program that focuses more on the family planning decisions should be aware that decisions are not dependent solely on knowledge, but it's also dependent on the social norms and the social consequences that women might face based on the misinformation on the fertility. And finally, integrating infertility into humanitarian sexual and reproductive health conversations might be integral in a sense that fear of infertility directly impacts their actions and their choices on the reproductive health, especially on the contraceptive use and the timing for the childbearing. Exactly 10 minutes. And thank you. I would like to acknowledge my master's reader, Dr. Lina Zimmerman, Dr. Shannon Noon, and also my advisor, Farah Qureshi. Thank you.
It was wonderful. Really, really important work. Very cool project. Great presentation. So we have about 5 more minutes for questions on this project as well. So please raise your hand or put in the chat if you have any questions. I'm so glad that you did a secondary qualitative data analysis. I feel like that's not a method that many people employ, and I think it's such a great way to use the data that you've already it's already been collected from this population. I apologize if I missed it. What was the original purpose of the qualitative data collection?
Yeah, it was a mixed method study focusing on early marriage and early childbearing. So it encompasses general sexual and reproductive health, married couples, decisions on contraceptive use.
Great. Yeah, what a rich data set to use for this project. It's fantastic. Sarah has a question. Go ahead, Sarah.
Hi, so Hyun. I was wondering, I'm guessing that in the area is like, because here in the US at least, if a couple wants to get pregnant, I know it's pretty common for the pregnant person to undergo sort of like tests and kind of like diagnostics to see if like there will be any issues to a pregnancy and stuff like that. Is that not a resource that people have access to in Bangladesh?
Maybe in Bangladesh, yes, but not necessarily in the camps where the health services is very limited. Some people did mention that they went to the hospital to test for the fertility, but it was only a couple of participants. And I think that the testing for whose side or the infertility more important, I think that's a really essential thing to do, in a sense that a lot of participants also recounted that yes, we don't know whose fault is this infertility, whether it's the husbands or the wives, but everyone just naturally gravitates toward it's women's fault.
Thanks. Great job.
Thank you.
The myths and concern about contraception was really fascinating to me. Is contraceptive care pretty readily available within the Cox's Bazar for women if they choose to use it?
It is available, and there's also MISP. It's Sexual and Reproductive Health Services for the humanitarian context, and it contains other condoms and other IUDs, I think. And it is available, but I think it also depends on the supply side, whether they could actually, it's not something that they could regularly get. And it might change depending on who's actually getting it from, like which organizations are getting it to the camp.
Yeah, and just the misunderstanding of kind of long-term impacts of contraceptive care is just, again, concerning. It's again really important information from your project. What are your next steps with this project? Are you planning to publish it?
That would be nice. That would be nice. But I think the first project related to this study was the child marriage. So I think that should be published first. And then the infertility part would be the next.
Again, secondary qualitative data is such a great resource. So we should publish it more often. So it's nice to see the utilization of that data. Great. Any final questions for Sohan? Well, with that, I am so grateful to all of you who presented today. This was a really wonderful session. Such great diverse topics, approaches, methods. I really hope those of you who were able to listen in learned a lot. I know I did. Thank you again for your hard work on your master's essays. And you're all finished, which is really exciting. So we have one more week of master's essays. And so please join us again next week to listen into our final groups who will be presenting. And thank you all again for joining us and for presenting today. So have a good rest of your day, everybody.